Welcome back to our YouTube channel. For those who have not subscribed, we urge you to subscribe so that you can join us in the journey of empowering one another. Knowledge is power. Today, I want us to look at implant infection. Implant infection is defined as infection that occurs due to the implantation. Here patients present with pain. They can have pain, they can have swelling, they can have sinuses, they even have discharge or even plurulent drainage from the affected side. So the risk factors of implant infection include surgical site infection, superficial infection which percolates in and it gets into the implant. Concurrent malignancies in the implanted patients, underlying joint or bone conditions like rheumatoid arthritis, psoriasis, poor nutritional status, and here is if protein energy malnutrition is present, and you find that protein is divided into two, where you have albumin, serum albumin, and microglobulins. So microglobulins are the ones which play a critical role in the immunity of a patient, whereby you have the IgA, IgG, IgE, IgM, helping in fighting infection. So when there is poor nutritional status, then you also have reduced amounts of microglobulins, which are important, like we said. Then you may have immunosuppression, like in patients who may have advanced HIV/AIDS, and that can affect them because they don't mount a good defense mechanism against infection, especially in inflammation, where the interleukins are reduced, interleukin 6 and tumor necrosis factor alpha 1. Then we may have cases of so remote infection can also be a risk factor, whereby you find a patient has infection somewhere in the body, which finally hematogenically gets into the implanted device, and therefore leading to infection. Maybe someone has pneumonia or a boil or a pharynx somewhere, and that can become a source of infection to the implant. You may also have a history of native bone infection or joint infection, and those can also lead to infection of the implant. So many factors may contribute to infection of the implants, like we've said, and even non-use of aseptic technique in theater can lead to contamination with commensal organisms, the organisms which are mostly found on the skin, getting contaminated with the implant and causing infection. Even sweat which drips, beads of sweat falling off the face or face of the surgeon or the assistant getting into the wound during surgery can also lead to infection. When you have a case of suspected implant infection, you need to take a clear history which is detailed, and then you investigate. So investigation can be either through laboratory, it can be through radiological investigations, and also by the criteria that usually we apply. Now, radiological investigations include use of a plain X-ray, and this one will be important especially for chronic or late phases. By the way, Implant infection is classified into early, intermediate, and late. Now, early lasts up to 1 month, intermediate over 1 month to 3 months, and above 3 months, then you say late or chronic phase of implant infection. Now, X-rays, plain X-rays will be able to show migration of implant or loosening of implant, or even bending and a periosteal reaction in some cases. So it will be important in the late phase, but intermediate and early phase you may not be able to see much, and therefore we prefer using CT scan, which can give you more details. So CT scan can be done, but sometimes because of the interference of the devices used, you may not get the right slices, and therefore it may be precluded. MRI as well may not be very useful, because most of the implants used in orthopedics, whether prosthesis or devices for long bone, they may be dangerous in MRI because of the huge magnetism that is used during investigation of MRI, and therefore that may be dangerous to the patient and also to the operator and even the machine. So unless it is stated and well documented that the implant that was applied in a patient was made from titanium or tantalum, then don't attempt to do an MRI. So the recommended investigation, radiological investigation, is radionuclide. Radionuclide is of high specificity, and it doesn't have problems with the kind of metal that is used. So it will be able to show you the extent of the infection. Laboratory investigations, we use, of course, the baseline investigations, full hemogram. Here you might be able to see leukocytosis in early and even some cases of intermediate infection, but not very useful in the late phase. You may have infection, but leukocytosis is minimal, almost normal, or actually normal. So in some cases you may find that. And then you can do C-reactive protein to monitor the response. We have a baseline and then you follow up your patient, or use of ESR, erythrocyte sedimentation rate. Now use of these two modalities to follow up patients may not be really important unless you combine the two. If you use one, then it doesn't really support you well, but if you use two of these, it is easier to compare and even follow up the patient. These investigations should not be one-off. They should be done serially as you follow up your patient, so that you are able to know whether the patient is responding to medication or the infection is also clearing. Then blood culture, very important. You can do blood culture to corroborate your findings from X-ray, history, and physical examination. Use of swabs from the sinus may be done, but most of the time they will yield something because of contamination from the nearby skin. So not very important. Deep tissues can be done, and actually whatever you get from the deep tissue culture, that will be an indication of infection. And then joint aspiration, you aspirate from the joint and culture. So and that brings us to the criteria used in the making diagnosis of implant infection. So we have criteria. Number 1, if you aspirate synovial fluid and culture it, and you get at least 2 you get the same microorganisms from at least 2 samples, that will mean a case of implant infection. And then when you examine the patient and find a track or a sinus, from the outside connecting to the implant, or you get inflammation in the tissues, deep tissues collected intraoperatively as reported. So any of those can indicate an infection of the implant. Once you've made a diagnosis, then you need to manage this patient. So management may include, depending on the phase, like we said, early phase, intermediate phase, and late phase. Early phase cases, you have to open up the patient, debride the area, remove the devitalized tissues, and then copiously irrigate the area, and maybe with the use of Dakins, loosely close the place, give the patient antibiotics, suppressive therapy up to 6 weeks. Then follow that patient using C-reactive protein and ESR. For phase 2 or intermediate phase, here it will depend on what you find. Just like in phase 1, you open up the patient and access the implant. So once you are in there, test for stability of that implant. If it is loose or unstable, then you remove it. Once you remove it, you have to debride the area, remove all the devitalized tissues, copiously irrigate the place using maybe Dakins, and then loosely close, and then follow up the patient. So if it is stable, you retain the implant and manage it like early phase. But if it is loose, you remove it and manage it as late phase. So the late phase, all of them you have to open, whether it is a prosthetic implant or just a device for long bones. Remove them because they are presumed to have a biofilm, and biofilm is what makes it difficult to eradicate infection in implants that have been infected. The biofilm always protects the bacteria, prevents antibiotics from reaching it, and that causes problems with management of patients and the restoration of function of the affected limb. So all cases of late implant infection, remove the implants, debride, use antibiotic beads or antibiotic spouses, give suppression therapy, and then follow up the patient. So for the ones who have prosthesis, for example hip, you can use antibiotic spacer after debridement, give suppression therapy, and follow up that patient. If there will be need, remove, for example, after 3 months or after C-reactive protein and ESR have shown that the infection has cleared, bring in the patient, debride again, and reimplant, but using new devices. If that's not possible, then you can do Gardostone, whereby you do resection of the head. That means you remove the implant, clean the area, and leave it like that. Yeah, the infection will clear, but there will be shortening of the limb, and sometimes that is all that you have to offer your patient. If it is the knee, sometimes you just remove the implant, debride the area, and do arthrodesis. You unite the bones together, and equally you end up with shortening on that side, but you may have pretty good, limb. Even if it is short, the patient will be feeling much better than with an implant, which is discharging pus. The suppression therapy I've been talking about includes use of rifampin. Rifampin is given 600 milligrams OD for at least a month, but you need to follow up your patient so that you continue giving it as it's required. And this is combined with levofloxacin, 750 milligrams OD for the same period. And this combination, prevents bacterial resistance. You can also add clindamycin, 300 milligrams TID for the same period. So these drugs actually reduce infection, or even you can claim some cure, if there will be no symptoms for at least 2 years. So if given as a combination for that long, and then you follow up the patient. So thank you very much for listening to me, and we request you to subscribe so that we continue interacting through this forum.